yourself available to have a quality time in Merlis from 7 p.m. onwards. And now for the moment, you all have been waiting for the quiz finals. I'd like to welcome Dr. Ganesh Rajagopal, Senior Consultant Radiologist, MMHRC, Madurai, and Dr. Arun Ramraj, SRH, Madurai, to lead this exciting session.
Good evening, guys. I am Dr. Ganesh Rajagopal, Senior Consultant Radiologist from Madurai, and my fellow quiz master is Dr. Arun Ramraj, Senior Consultant of Sri Ramakrishna Hospital, Coimbatore. We all know that you are so tired after a hectic day schedule. Okay, so we'll make it this quiz program little funny. I assure that. First, I invite the 8 teams, the final. Who are the 8 teams, please? Guys, 8 teams, please. Quick. So you guys are from KMCH. Okay, you are the number 1 team. First number, please. Number 2 is. Okay, who is the number 2? From Kaveri, Chennai. Number 3 is from Ramakrishna, Coimbatore. Number 4. Where is the 4 team? They cannot escape from this quiz. Pet detectives. Where are that guys? Team 4. Okay, we'll wait for them. Team 5. Somebody called them actually.
Pixel
Team 4.
Resorts. 4th. Pixel Resorts. They are there. Okay. Next is
Just a minute. Team 4 from which college? Jimmer. Okay. Then
Pixel Resorts. You are okay. Radio Glare.
This come this time. Please come this time. Your number is team 6. Okay. You are from Ames, Hyderabad.
Then Magnetic Minds.
Magnetic Minds. Who are that guys? You are from. So why you have named us Magnetic Minds? You are interested in MRI physics?
You just call other.
Okay, great. You are from KMCH. You? Okay, you are number team 8. So 1.
The last
2,
is Star Strikers, I think.
Yeah. Okay, we leave that names. Now we will go to the college names.
Okay.
1, 2, 3, 4, 5, 6, 7. So 7 teams are here.
Silhouette is missing. Silhouette is. Then who is missing? Pixel Resorts. Pixel Resorts. Then Pet Detectives.
It's very unfortunate we are not getting one team. Those who are selected for the finals.
Coming. So you are which team? Go.
Come here. You are the team. 4. Which college? Madurai. Okay, great. Please take your seat. So 1, remember your number. 1, 2, 3, 4, 5, 6, 7, 8. 8 teams. Arun? So there are 3 rounds. The first 2 rounds will be taken by Arun. He will give you 1 case as usual. So 2 cases per round. I will give you a case file which contains a collection of cases. So scorer, you are the scorer. So each round carries 100 marks. So 3 rounds, 300 marks. The top 3 will be selected.
Yes. Shall we start? The first case is to team 1. Here is a 70-year-old female who presented with chronic dry cough. She is a known case of metastatic carcinoma endometrium on treatment for the past 2 years. These are the post-contrast. These are lung window images. All the findings are marked there. These are the mediastinal window showing calcified lesions everywhere. This is a PET CT image. All the lesions are showing FDG avidity. Elderly female with metastatic CA endometrium on treatment for last 2 years. There are calcifications everywhere showing FDG uptake. Yes?
Lymphangitic carcinomatosa involving right lungs.
Why it has to be calcified? Oh, if you are not sure, you can pass. Can we?
Yeah, please. If you don't know, you please pass the question so that we will wind up quickly.
Some type of mucinous endometrial CA with metastasis.
Okay. It is not there. Next.
There are diffuse interlobar septal nodular thickenings
Yes.
on right side. Few of the septal thickenings are calcified, and there are also calcified mediastinal nodes.
Yes.
And we also saw some calcifications in kidney,
Okay.
and there are bone lesions too in the right pelvic bone, likely calcified metastasis.
No. Next.
Can this calcification be due to post-treatment
Yes.
changes in the previous metastatic lesions?
No.
Secondary lymphoma.
No. Anybody of the other teams?
Endometriosis.
It is the patient is a known case of metastatic CA endometrium. She was treated 2 years back. Now she has only chronic dry cough. There are no other complaints. She is taken the PET CT every year. The last PET CT was taken 2 years back, also showed similar lesions. Yes? Okay?
Synchronous osteosarcoma with calcifying mets
Osteosarcoma.
of the ileum with calcifying mets.
No. The last team?
Superimposed TB infection.
No. Okay, I will give a clue. This patient had an increased serum calcium. Yes. See, it is a case of metastatic pulmonary ossification, which is a metabolic lung disease commonly associated with patients with end-stage renal disease with serum hypercalcemia. But it can occur in patients with massive osteolysis. Massive osteolysis from metastasis or multiple myeloma. The classical findings will be multiple or diffuse calcified nodules or high density consolidations with upper lobe predominance. See here, only the upper lobe is involved. When compared to the lower lobe, there is relatively sparing of lower lobe. And the calcification can be seen in myocardium, bronchial wall, small pulmonary arteries, SVC, dura of spine and chest wall vessels. Here there are calcifications in the pulmonary vessels. So it is a case of metastatic pulmonary ossification. So the next case is to the team 2. This is another patient with high density consolidation in a case of myeloma with elevated serum calcium. So it is to team 2. It's a 13-year-old female who presented with bleeding from gums and abdominal distension. The patient was sent for ultrasound. These are the ultrasound images of the uterus and ovaries. The age of the patient is 13 years. The size of the uterus, ovaries, everything are mentioned there. You'll go for next slide. There are images from both kidneys showing some hyperechoic lesions in both kidneys. The lower one, this is the spleen, and this is the liver. Coming to right iliac fossa, there are some abnormalities in the right iliac fossa. There is a node here. There are some abnormalities in the right iliac fossa. So what could be the diagnosis? 13-year-old female with enlarged uterus, ovaries. See the ovaries here. Next team.
It could be lymphoma because
Yes,
the shapes
excellent.
are maintained.
See, it is a case of extranodal lymphoma. See, everywhere the lesion is infiltrative pattern with preserved architecture. Both the ovaries are solid, and the follicles are seen in the periphery. There are multiple lesions in the kidneys. There is splenomegaly, and there are lesions in the right iliac fossa. See, these are the corresponding CT images in which we are able to see the supradiaphragmatic lymph node, multiple lesions in both kidneys. See the enlarged uterus, vagina, ovaries, and the involvement of the bowel loops in the right iliac fossa with interception. So coming to extranodal lymphoma, commonest is the GAT. Gynecological tract involvement is very rare. It is common in ovaries, followed by cervix, uterus, and vagina. And the classical imaging picture here is the infiltrative pattern with preservation of architecture. So next case is through the team 3. Here is a 16-year-old male who presented with left vocal cord palsy. These are the post-contrast CT images. The middle one is the PET CT image. It is the same, the images of the same patient taken 2 years back. This is the image 2 years back, and now this is the current image. See, there are 3 densities within the lesion. Yes. Next team. Pass. Next team.
Thymic carcinoma.
Yes.
Thymic carcinoma.
Thymic carcinoma. No. Next one.
Pass.
Pulmonary sarcoma.
Pulmonary sarcoma.
Angiosarcoma.
Okay. No, there is not much enhancement here. Next team. So it started with 3. So first team. Second one. See, the last 2 years back there is a uniform density lesion here. There is no solid component. Now the lesion has become cystic. There is a layering milk of calcium here. And anteriorly there is solid enhancing solid component which show FDG. So it is a case of bronchogenic cyst with adenocarcinoma from bronchogenic cyst. So typically the bronchogenic cyst will usually occurs near the trachea or carina, and it will be single smooth elliptical cyst with imperceptible wall and uniform density. Layering milk of calcium is classically seen and is best seen on CT. The rare complications are secondary infection, intracystic hemorrhage, and malignant transformation, evidenced by increase in size with appearance of solid components. So it is a case of adenocarcinoma from bronchogenic cyst. So next to team 4. Here is a 52-year-old female who presented with dysphagia with loss of weight and appetite. Endoscopy has been done and has been diagnosed as gastric adenocarcinoma. So these are the CT images. Esophageal wall thickening, gastric wall thickening is there, and all the findings are marked here. Liver, there are some findings are there, and this is the next set of image showing some abnormalities there. I want to know the pathway of spread of gastric adenocarcinoma in this case. Team 4.
Gastrohepatic.
Yes.
ligament spread.
Yes, excellent, excellent. So it is a subperitoneal spread of tumor. So coming to the pathway of spread, there are lymphatic dissemination, subperitoneal dissemination, direct invasion, transperitoneal seedling and hematogenous dissemination. Here tumor invasion along the perigastric ligaments may cause direct invasion of the adjacent organs and is considered as T4B disease and not metastatic disease. This is a teaching point here. And the various ligaments you have to study are gastrohepatic, hepatoduodenal, gastrocolic, gastrosplenic and splenorenal ligaments. Here hepatoduodenal ligament is involved as there is involvement of the porta hepatis, there is involvement of the portal vein, CBD, and there is some subtle alteration in the pancreatic head. So it is a case of CA stomach with perigastric involvement. There is involvement of the hepatoduodenal ligament. So it is a case of CA stomach with hepatoduodenal ligament involvement. Gastrohepatic ligament will extend from the lesser curvature of stomach and to the inferior surface of liver. Here there is a involvement of the gastrohepatic ligament with a lesion in the left lobe of liver. Another patient showing infiltration of the from the fundus of stomach. There is involvement of the spleen here. It is gastrosplenic ligament. Splenorenal ligament will extend from the spleen to the left anterior perineal space with involvement of pancreatic tail and splenic vessels close to the hilum. And this is the gastrocolic ligament which extends from the greater curvature of stomach to the transverse colon. This is a gastrocolic ligament, and the greater omentum is a fatty apron which extends from the transverse colon and surrounds the small bowel and the anterior aspect. Here it is greater omentum involvement. So this is the spectrum of perigastric ligament involvement in a case of CS stomach. So next is case team 5. Here is a 53-year-old female who presented with right upper quadrant pain, and ultrasound was done outside and it showed multiple hemangioma and one of the lesion was heterogeneous. And after follow-up after 6 months, there is slight increase in size of the heterogeneous lesion. So this is the CT image, plain CT, early, late arterial, venous and delayed phases.
Angiosarcoma.
Yes, first describe the lesion. Describe the lesion.
So it shows
See,
arterial hyperenhancement in the
yes, there is
then progressive.
there is hypervascular enhancement here, and there is central central necrotic area,
Yes.
peripheral.
Peripheral rim is there, sir. And
Okay.
then the progressive enhancement is there.
Okay, there is no washout. There is a fluid level here. Do you want to revise your diagnosis?
Sir, can you go back, sir, again? Can we see again? Which is
Angiosarcoma is common in elderly males.
hemangioendothelium.
Yes?
Hemangioendothelium.
Hemangioendothelioma. Okay, it's not there. Next team.
It's a cholangio.
No, madam.
No.
Next team. Next one. Team 1. Sclerosing hemangioma. No. Next one.
Neuroendocrine
Yes,
mulberry
it
appearance.
is a primary neuroendocrine tumor of liver. See, it is a primary neuroendocrine tumor of liver, which classically primary neuroendocrine tumor of liver is very rare. If you see a neuroendocrine tumor in liver, you have to look for metastasis from pancreas and small intestines. It is usually a single heterogeneous hypervascular mass with central necrosis and peripheral solid component. Typically, fluid level will be seen, and there will be early arterial enhancement with no washout, and central cystic component and peripheral enhancing component will resemble as a mulberry appearance. So another patient with primary hepatic neuroendocrine tumor showing a central cystic area and a dotavid solid component in the periphery, typical mulberry appearance, and another metastatic patient from the metastatic neuroendocrine from the pancreas showing typical fluid level in the liver. So this is to team 6. Here is a 37-year female who presented with bleeding per rectum and abdominal distension. She gives history of right hemicolectomy done few years back. So these are the post-contrast CT images taken at the level of rectum. I will show the next set of image. She gives history of right hemicolectomy. This is the last reformatted image. Bleeding per rectum. There is some lesions, multiple lesions are there here. She gives history of right hemicolectomy few years back. Yes, next team. Yes. See, basically there are multiple lesions here.
Due to recurrence.
Yes.
Recurrence.
Recurrence. Recurrence from? See, there is a abdominal. In the abdominal wall, there is a mass is there. The long axis of the mass is along the long axis of the muscle. Yes. Next. Yes.
Desmoid.
Yes. This is a desmoid. You call it correctly. So other findings are also there, no?
Desmoid tumor with metastasis.
With metastasis.
Any other packages with desmoid?
See, I have told it is right hemicolectomy. The patient is having multiple lesions in the rectum. Yes.
Is it Peutz Chaker with like
Peutz Chaker. No.
with the dermat?
Yes. It is team 1 has answered.
Has given
It
the
is a
answer.
Gardner syndrome. See, the patient is having multiple polyps in the colonic polyps. Multiple colonic polyps are there, and there is a desmoid tumor. So it is an autosomal dominant type of familial adenomatous polyposis. See, the patients will have osteomas of the mandible, skull, and long bones, and will have desmoid tumor of the abdominal wall and mesentery. There will be some dental abnormalities like supernumerary teeth, odontomas, dentigerous cyst. And the teaching point here is, whenever you see a patient with osteomas and some dental abnormalities, you have to screen for colonic polyps, because extracolonic features often precede the colonic polyps. So this is the image of the same patient showing osteomas in the paranasal sinus and in the calvarium. This is to team 7. It's a 67-year-old male who presented with vague upper abdomen pain. Ultrasound done elsewhere showed some heterogeneous lesion, reported as likely GIST. These are the plain CT image. There is a soft tissue dense lesion here. There is a peripheral calcification. These are the post contrast image. Post contrast image. Pancreas, there is duct dilatation. Yes.
Malignant GIST with obstruction.
See, the lesion is not arising from stomach. It is arising from. See, this is the duodenum.
Dilated MPD is also there.
Yes.
Dilated MPD is also there. So the lesion can probably arise from the head of the pancreas. Can be adenocarcinoma.
Calcifications are very rare in adenocarcinoma. So next team.
Lymphoma.
Next team. Age is 64. Team 2. Next team.
It's a heterogeneous lesion with peripheral calcification. Age group is unlikely, but it can be a spin.
Yes, correct. It is a solid pseudopapillary tumor of the pancreas, and it typically it occurs as enhancing solid component in the periphery with cystic component in the center. Peripheral calcification may be seen. Coming to pancreatic tumors with calcification, neuroendocrine tumor will have peripheral rim-like calcification. Mucinous cystoadenoma will have peripheral curvilinear calcification. Serous cystoadenoma will have central calcification, and adenocarcinoma calcifications are very rare. Coming to team 8, So here is a 63-year-old female who presented with left-sided neck swelling and hoarseness of voice. Ultrasound done elsewhere reported as a large heterogeneous lesion with calcification in the left parathyroid region. This is the plain CT image showing a calcification there. These are the post-contrast images. Yes.
Adenoma.
Adenoma. This patient is having calcification. There is some heterogeneous enhancement.
Parathyroid carcinoma.
Yes, excellent. It is a case of parathyroid carcinoma. So the difference between parathyroid carcinoma and adenoma, parathyroid carcinoma will be larger in size and it will be taller than wide. It will be taller than wide with irregular shape, indistinct margins, irregular margins, intranodular calcifications and cystic change. So this is a case of parathyroid adenoma. See the size here, it is smaller in size, it is wider and it is separated from thyroid by an echogenic capsule with a characteristic extrathyroid vessel with a ring or arc-like vascularity. So this is adenoma, this is carcinoma. This is wider, here it is taller, calcification, heterogeneous enhancement, lobulated margin, everything points to malignancy. It is a case of parathyroid carcinoma. So it is to team 1.
Team 1. This is the second round.
Yes sir, this is second round.
Team 1.
Yes, the team 1. Here is a 48-year-old female who presented with recurrent epigastric pain. These are the plain CT images. Plain CT images. These are post-contrast images. There is a lesion in the pancreatic tail here with some calcification. There are few findings in the kidneys here. There is some lesion in the duodenum. There are another lesion here. 48-year-old female with recurrent epigastric pain. So there are multiple lesions here. Pancreatic lesion with peripheral calcification. Yes. Give mic to them.
Multiple.
Mucinous adenoma.
Madam, there are multiple lesions here. Okay, give it to the team 2. Yes, sir. You started correctly.
Multiple cysts.
Multiple cysts.
With mets.
Okay. Where is the cyst? Primary cyst is this here.
No,
Primary is here. See, there are multiple calculi here.
Yes.
Okay, team, next team.
Multiple cysts.
Okay, next.
Multiple endocrine neoplasias.
Yes, it is a case of multiple endocrine neoplasia. See, there are it is hyperparathyroidism. So the patient is having mitral renal calculi. There is a paraganglioma here with peripheral calcification. Just now I showed there is a peripheral calcification. It is a paraganglioma. There are some paragangliomas here in the duodenum. There is a carcinoid in the stomach. So it is a case of multiple endocrine neoplasia type 1. There are pancreatic, parathyroid and pituitary tumors. And the same patient is having a right parathyroid adenoma here and a heterogeneous solid cystic mass lesion in left lobe of thyroid and pituitary macroadenoma. See, another companion case to the same team. So it is a, no. This case is a companion case. So it is a 29-year-old female. There are multiple renal calculi and there is an enhancing lesion in the adrenal gland. Okay.
Pheochromocytoma.
Yes, it is a case of pheochromocytoma.
MEN2.
So this question doesn't carry marks. Okay. So it is a case of MEN2 syndrome. That is pheochromocytoma, parathyroid hyperplasia and medullary carcinoma thyroid. So this is to team 2. Okay. This is a 47-year-old female with swelling in right side of neck. This is a ultrasound image. This is the right lobe of thyroid. Carotid is here. IJV is here. This is the elastogram image. Elastogram image. I'll go to the MR images on T2. See the T2 images here. Diffusion, T1. Post contrast image. This is the first phase. This is the second phase.
Paraganglioma.
Paraganglioma. Okay. Paraganglioma is a nice one. But here there is no intralesional vascularity, no flow voids. The lesion is homogeneously hyperintense. Yes. Team 3.
Carotid body tumor.
Team 4.
Peripheral nerve sheath tumor.
5. See, they are ready with the answer. They are waiting for that. Team 1.
Branchial cleft cyst.
Madam, it is enhancing. This is solid lesion. Yes, next one.
Cystic schwannoma.
Madam, the lesion is solid. See, it is very bright on T2. There is some enhancement here.
Schwannoma.
Excellent. It is a case of hemangioma of the carotid sheath. So, carotid sheath hemangiomas are extremely rare. The findings here are, it is hyperintense on T2 and it shows a nodular avid enhancement on early phase followed by centripetal filling on delayed phase. And when compared to other vascular masses of the neck, here is a carotid body tumor, can appear hyperintense on T2, but it will show salt and pepper appearance on T1. There will be splaying of internal and external carotid artery. Vagal schwannoma will displace the carotid anteromedially and IJV posterolaterally. Sympathetic chain schwannoma will displace the carotid IJV laterally, and in case of neurofibroma, there will be central T2 hypointensity, that is target sign. So these are the differentials. So this is a case of carotid sheath hemangioma. So this is to
Team 3.
Team 3.
3.
Yes. Here is a 48-year-old male who presented with epigastric discomfort. He gives a history of metastatic hilar cholangiocarcinoma treated with surgery, chemotherapy and concurrent radiotherapy in 2018. These images are taken in 2020. These are the T2 weighted images. There are some abnormalities here and there is a lesion here. I have marked all the findings here. I don't know. So these are the fat sat T1 weighted image. See the difference here. There is a lesion here. Next one. Last one is a post contrast image. Post contrast image, thin ring enhancement or peripheral enhancement.
Abscess.
The clue is here. Okay. Next team. See, the patient was treated 2 years back. Now he is coming with only with epigastric discomfort. There is a new lesion in the liver. How will you proceed with that? Next case. So it is not recurrence. Next one. See, the clue is here.
Previous lesion was cholangio, sir.
Yes, it is hilar cholangiocarcinoma.
So it is peripheral.
Next one.
Cholangio.
Anybody? It will started with. Okay. Next image. Oh. Okay. So no points for any team. So it is a case of radiation-induced liver disease. See here, there is difference in signal intensity in the liver. See, it is with a well-defined linear margin. This area appears normal. Here it is hyperintense on T2. Here on T1, then this area appearing normal, and here it is appearing like hypointense. And the clue here is in this image. See the radiation, everything is within the radiation port. So all the lesions are within the radiation port. So it is a case of radiation induced liver disease. So, the same patient. See the 2018, pancreatic duct is normal. 2020, it is mildly dilated. 2023 is significant dilatation of the pancreatic duct. 2024, there is significant dilatation of pancreatic duct with a T2 hypointensity lesion in the pancreatic head, not showing any restricted diffusion. It is pancreatic fibrosis secondary to radiation. So, it is a case of radiation-induced liver disease. So, another patient, esophagus with epigastric lymph node, treated with radiation. There is a hypodensity in the radiation field. So, it is a case of radiation-induced liver disease, which we rarely come across. So, it is to team 4. It's a 18-year-old male who presented with right upper quadrant pain and jaundice. So, these are the these three images are the plain CT image. This is the arterial face image. There is some differential density here. And these are the further arterial venous face images. 18-year-old with some cystic lesion with heterogeneous density here, and there are some. Yes.
Biliary cystadenoma with a malignant transformation.
Okay. Biliary cystadenoma will have a lot of vascularity here. Next team. You think of pediatric tumors. Next one. Last one. Yes, it is a case of undifferentiated embryonal sarcoma. See, coming to pediatric tumors, there are two cystic tumors common. One is mesenchymal hamartoma, which is a benign lesion. It will be present in an age less than 5 years. There will be cystic lesion with a progressively enhancing solid component. Here, the important take-home message is it is a predominant solid-like lesion in ultrasound and cystic lesion and CT due to presence of myxoid content. The cystic lesion with internal vascularity on a CT in a liver in a pediatric age group is undifferentiated embryonal sarcoma. Tumor markers are not elevated, and see on the MR images due to the myxoid content it is very bright on T2. So this is a case number 13 to team 5. Here is a 36-year-old male who is a known case of chronic kidney disease on hemodialysis. He is a long-standing diabetic. He is on hemodialysis. He presented with chronic coarseness and cough. These are the plain CT images. Plain CT images. There are some findings here. Lung appears normal. The lung, there are no findings. Everything was normal in the lung. So there is some involvement of the trachea here. These are the axial T1, T2, and these are the sagittal and coronal images showing the longitudinal extension of the lesion. So what could be the most likely diagnosis? Next team. Yes.
It's amyloidosis.
Very good. It is a case of tracheal amyloidosis. See, the classical here is posterior wall involvement. Rest of the disease of the trachea won't have predominant posterior wall involvement. Here there is predominant posterior wall involvement, and tracheobronchial amyloidosis is extremely rare, and there will be thickening of trachea, main lobar, segmental bronchi with or without calcification, and predominant posterior wall involvement. This is the teaching point here. So this is 6. Here is a 70-year-old male who presented with upper quadrant pain and loss of appetite. This is the plain CT image. Given the plain CT image, there are multiple lesions here. This is to understand the contrast kinetics, I have given only few images here. This is the plain CT. These are the arterial phase, venous phase, and these are the delayed phase images. This case is from Gem Hospital. It was given to me by my friend. So there are multiple lesions in the liver. See, there is some finding here. Multiple abnormalities here. Yes, madam.
It's a infective possibility of like echinococcus multilocularis or
No, it is a close DD for infective cause. Okay, next. Next one. Yes, team one. So you are ready? Yes. No. Next one. Scalloping of? See, there are multiple lesions in the liver. All of them are subcapsular in location. There is capsular retraction. Yes.
Hepatic hemangioendothelioma.
Yes, exactly. It is a case of hepatic hemangioendothelioma. See, there are multiple lesions in the liver here. All of them are subcapsular in or in the periphery, and there are capsular retraction at multiple levels. And there is a classical sign here, described here. See, yes, yes, lollipop sign and target sign. See the target sign in the plain CT, there will be a hypodense area followed by a uniform hypodense rim. And on lollipop sign, the tumor forms the body and the vein forms the lollipop stick. So it is a case of hepatic epithelial hemangioendothelioma. Is a companion case. Here you see there are similar lesions are there. Here there is a segmental atrophy with some more calcification in the left lobe. These findings, along with the presence of active pulmonary TB, hepatic tuberculoma can also is a mimicker for this condition. So it is a companion case. This case is hepatic tuberculoma. This patient had active pulmonary TB. So this is for team 7. It's a 61-year-old male who is a known case of myelofibrosis. He presented with bleeding per rectum and pain in the abdomen. On examination, there is a vague mass felt in the right iliac fossa. These are the ultrasound images taken at the level of right iliac fossa. This is in the pelvis, this is the spleen, this is the liver. So right iliac fossa, pelvis, spleen and liver. So I'll go to the CT. These are the corresponding CT images. Reformatted image. So there is a lesion in right iliac fossa, there is a lesion in the pelvis, there is splenomegaly. The patient is a known case of myelofibrosis with bleeding per rectum. Yes, sir. See, I have given the clues as well. The patient is a myelofibrosis. Yes? Next one. Yes, madam. It is a case of extramedullary hematopoiesis. See, it is a case of extramedullary hematopoiesis. It's a rare tumor occurring in myelofibrosis, but can also be described in essential thrombocytosis, acute B-cell leukemia, and myelodysplastic syndrome. It is nothing but extramedullary hematopoiesis with a fibrotic background. It can be seen in liver, spleen, kidneys, lacrimal gland, retroperitoneum, mesentery, thyroid, lung, lymph node, GAT, kidney, skin, and breast. So coming to the last team, team 8. Here is a 42-year-old male who presented with vomiting and loss of appetite. He is a long-standing diabetic. He is on insulin. 42-year-old male with vomiting and loss of appetite. There are some lesions here. Some lesions here. See here, there are some lesions here. And there are some other lesions in the similar lesion in the body as well. So what could be the diagnosis? Team 8. See.
Somatostatinoma.
Yes?
Somatostatinoma.
No, see here. There is a large lesion is there. Not much enhancement. Yes. Just. Okay, team. Lymphoma. Next team. Yes. Huh? No. See, the patient is a long-standing diabetic. He is an immunocompromised individual. There are some lesions there in the stomach. Okay, here there is a hypodense wall thickening involving the gastric fundus. There is ulceration here. There are intramural air. See, there are intramural air here. There is extension of lesion from the across the wall to the perisplenic region here. Yes, madam.
It's candidal or
Exactly, madam. It is a case of fungal infection. It is a primary gastric aspergillosis. See, the lesion is hypodense. See the wall thickening here. It is a purely hypodense. There is ulceration, intramural air. The take-home message here is spread of the lesion from the mucosa along the serosa, is cross the serosa to the perisplenic region with left pleural effusion. So, in a immunocompromised individual, it is a case of primary gastric aspergillosis. Primary gastric aspergillosis in the stomach is very rare. It will be typical low attenuation gastric wall thickening with transmural infarction secondary to fungal hyphae invading the small blood vessels with hemorrhagic infarction. There will be large defect in the posterior wall with intramural air. It's a companion case, hypodense wall thickening. It will be mucinous adenocarcinoma with, it will have punctate calcification. So with this, I end the round 2. It's over to Dr. Ganesh. இதானே சார்?
ஆடியோ வருங்க. நீங்கள் உட்காருங்க. Okay, Arun has done a nice job, but the cases are very difficult. But my case files are going to be very easy. The way you interact with me is going to give the marks. So remember that actually. So I thank the organizing team KMCH, Venkatesh, Rupa, and Mr. Rajesh for the invitation. There are 8 case files are there. So these are the 8 numbers. You please select from one. Select one number randomly. That's your lucky number. 5, 8, quick. 2, 3, 4, 5, 1, 7. So remaining is yours. Okay. So this is an oncology conference. So my case files are based on oncology theme. Okay. So who is one? Okay. For you, when the tumors bleed is the case file. Before that, we'll relax for a little bit.
என்ன வயலு ஒரு 8 நாள் பீடி குடுற தம்பி. என்ன பீடினே? பூமாருக்கு பீடி குடு. இந்த அருக்கு பக்கத்து ஊரு 1.5 கிலோமீட்டர். மழை அப்படி பெய்யுது. இந்த ஊர்ல தான் அப்படி அநியாய வெயில். சட்ட ஓவரா. ஏமா குடுமா சீக்கிரம். இருனே தேடி தானே எடுக்கணும். நம்ம யார் வம்புக்கும் போறது இல்ல, யார் தும்புக்கும் போறது இல்ல. நம்ம உண்டு நம்ம சோழி உண்டுன்னு போயிடுறது. என்ன பொழப்பு. மனுஷன் இன்னைக்கு இருப்பான் நாளைக்கு இருப்பான் நாளை கழிச்சு ஊருக்கு போடாம இருக்கேன். அங்க என் தங்கச்சிக்கு சடங்கு.
உனக்குதான் தங்கச்சி இல்லையா, ஏன் போய் சொல்ற?
இல்லப்பா, சின்னம்மா மக. குடு.
பிடியே இல்லனே.
இல்லாட்டாலும் பரவாயில்ல, சுருட்டாதான் குடுறா. பகுத்த கலக்குது. குடு. கெட்ட நேரம் இருந்தா ஒட்டத்துல உட்கார்ந்தாலும் நாங்களா வர்றோம்.
என்ன பாத்துக்கிட்டே இருக்க?
எது? ஆர் பார்த்தா?
நீதான்டா குரு 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 குருன்னு பாக்குற.
குரு 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 நாங்க பார்த்தோம். ஆஹா.
என்னடா சவுண்ட குடுக்குற? சில்லற காசு எவ்வளவு வச்சிருக்க?
சில்லற காசு
எடு.
போப்பா, நானே பீடி வாங்க காசு இல்லாம எட்டனா கலா நடந்திருக்கேன்.
Okay, so first for you, tumors bleed, okay? So what are the liver tumors bleed? Give me examples. Give the mic to her. So Rajesh, team 6, okay? Yeah.
So first is giant hemangioma, if it
Yeah, hemangioma, yeah.
next is hemangioendothelioma.
Okay, see this patient, an elderly patient, 72 years male. I have given only the delayed image, which shows that the entire contrast has been washed out and massive hemoperitoneum in the second, third, fourth images. What is the tumor? Elderly guy. Elderly male patient. HCC. Hepatocellular carcinoma is the most common thing. Okay, one time one patient with a diagnosis of hemangioma came to us. We tried biopsy the lesion. It turned out to be a bleed like this with massive hemoperitoneum. This is a bleeding hemangioma. When you see a young patient like 20 years with fat in the liver lesion and massive bleed, what you will think? Fat in the lesion. Female on oral contraceptives.
This is fibroadenoma.
Yeah, adenoma. Yeah, exactly. That's a bleeding adenoma. This is a pediatric patient. Okay, now coming with acute abdomen, there is a massive blood products in the left lobe of the liver. The contrast CT shows hypodense, non-enhancing areas, which is the reason for the blood. In the pediatric patient, which liver tumor bleeds?
Hepatoblastoma.
Exactly, this is the case of hepatoblastoma. Okay, so the hepatic tumors sometimes suddenly bleeds and presents acute abdomen. The HCC, hemangiomas, adenomas, hepatoblastoma, everything bleed. We need proper protocols, that is the 4-phase CT, and if the patient is hemodynamically unstable, we have to do embolization. Coming to the GI tract, name one GI tumor which bleeds and presents as melena.
Mostly ulcers.
Ulcers, yeah, malignant gastric ulcers, yes.
It is and dysplasias, angiodysplasias.
Okay. So this patient's CT angiogram shows a contrast accumulation in a jejunal loop on the right side of the abdomen. This is a bleeding polyp. Okay. See this video. The entire the cause for the GI bleeding is in the lower abdomen. That's a reason for the GI bleed. I'll show you the intraoperative picture. Okay, you see there is a afferent loop and the afferent loop, and there is a large exophytic mass. This mass is ulcerated, is communicated with the bowel. So again see the imaging. Two bowel loops and a large exophytic enhancing mass. Possibility? Which malignancy, GI malignancy has large exophytic component?
Mostly this gist.
Yeah, exactly. This is bleeding gist. When the renal tumors bleed, name one renal tumor which bleeds. Common.
RCCs.
RCC, then number 2.
The
Okay. Very good. Okay, I am seeing actually a fat dense lesion in the upper pole of the left kidney, and there is an foci of increased enhancement in the upper pole. Same patient, and the volume rendering shows an aneurysm formation in the upper pole, fat in the left renal lesion. Angiomyolipoma. This is a case of angiomyolipoma. This is a large angiomyolipoma with extensive bleed and multiple aneurysms in the perinephric region. So that's it. That's a case file for you. You can relax. Who is having number 2? Okay. Team 3 is having number 2. Okay. Please, Rajesh, please note. Team 2. No, here, team 3. Okay. Tumor mimics. See, we say tumor in imaging, but they are not. See, in real life, if you say a patient, you are harboring a malignancy, then it causes unnecessary panic actually. So we have to be very strong in identifying the tumor mimics. We'll see few examples. The ultrasonogram shows a calcified mass within the bladder. Give 2 differentials.
Schistosomiasis.
Schistosomiasis is very, very rare in India. Tuberculosis is okay. Tuberculosis causes wall calcification, but never a calcified mass such like this intraluminally projecting into the bladder. No.
TCC.
Yeah, the most common calcified mass in the bladder is TCC. Yes. The smart radiology resident doesn't stop there. Actually, the radiology resident, now I am giving you the scanogram. The radiology resident reviews the scanogram, the X-ray of the IVU very closely and found out the diagnosis. Can you able to make out the diagnosis?
Concentric calcification.
Concentric calcification is there inside the bladder, but what is the reason for that concentric calcification? Any other, whether the arrow is okay. Can you see something is here?
Like a copper T kind.
Very good, very good. It's a copper T. It's IUCD migrated. The vertical limb has gone inside the bladder. All the calcium is been encrusted and formed around the bladder. So when we do ultrasonogram, we see only the calcium inside the bladder, not the underlying copper T. So only the X-ray and the CT gives you the proper diagnosis. This is the sagittal image which shows the vertical limb, how the vertical limb placed, how the horizontal limb placed. I have given a diagram also to really explain what is happening actually. So that's a migrated IUCD. Another patient with calcified mass in the bladder. This time the patient is giving you a history. I had an inguinal hernia surgery 1 year back.
Maybe a suture that is granuloma.
Partially correct. Okay, you are saying something related with the surgery, but this is an inguinal hernia surgery and there is a calcified mass in the bladder, same like our old patient. Any correlation between
the mesh wire might
very
have migrated.
Good, exactly. Yeah, that's a migrated mesh. See, I'll give you a companion case. You see them, they keep the mesh in the inguinal canal. It sometimes fails. It starts to migrate. It goes towards the bladder, causes lots of inflammation. Sometimes it enters the bladder and forms an encrustation of calcium, which is the reason for the second thing. So remember, these are tumor mimics. They are not TCCs. They are just foreign bodies which are away from their normal position. Another tumor mimic. Both ultrasonogram and CT shows retroperitoneal mass. The patient is ready for surgery. Before that, we did a CT. I have given you the window little adjusted. I make the window with narrow sittings to highlight what is happening in the mass.
It's hyperdense.
Yeah, hyperdense. Then what does it mean?
It can be a hematoma.
Hematoma. Then what you will do next?
I will suggest a contrast CT.
Yeah.
Tumor.
I'll give you the contrast CT angiogram.
Pseudoaneurysms are there.
Where? Which artery?
Adrenals.
No.
Can
Adrenals,
see
they arise from the aorta.
the axial cut.
Okay, this is arising from the GDAs. Okay, there are two aneurysms arising from the GDA, and this is the reason for the large hematoma in the retroperitoneal compartment, not any malignancies. Again, a tumor mimic. So these hematomas, wherever they occur in the GA tract or in the abdomen, they are always a headache in ultrasonogram and CT MRI if you not carefully analyze that. So I have adjusted the window settings. This is first initially reported as appendicular mass, later turned out to be intramural hemorrhage, esophageal hematoma, duodenal hematoma, and jejunal intramural hemorrhage, rectal intramural hemorrhage, which mimic here rectal gist. Remember, these are not tumors, they are just hematomas. We'll find a reason and we'll make sure that we don't mistake the common as tumor cancers. We'll review the plain CT and check the bleeding parameters. So we have given gastric adenocarcinoma with the left lobe of liver infiltration. The biopsy was taken. It's not malignancy, it's not adenocarcinoma, it's just a tumor mimic. The treatment was started. After 6 months, everything is gone. So which benign condition mimics gastric adenocarcinoma in the stomach?
Inflammatory pseudotumor.
1.
Tuberculosis.
Tuberculosis, yes.
IgG4 disease.
IgG4, okay. So eosinophilic gastritis. So eosinophilic gastritis is a rare inflammatory condition characterized by excessive eosinophil infiltration in the stomach lining. The gold standard is the upper endoscopy with biopsy showing more than 30 eosinophils, okay. So remember, it mimics a gastric adenocarcinoma. So that's all for you guys. Number 3, yeah. When the tumors obstruct, this is easy actually. There are many tumors in many systems which presents as obstruction. What's the sign called as?
Target sign.
What does it mean?
Intersusception.
Okay. What's the coronal reconstruction shows?
Lipoma.
Complete diagnosis. Need the complete diagnosis.
Intraluminal lipoma with the intersusception.
Yeah, this is a colocolic intersusception with the lead point as the lipoma. Okay? Correct. So that's the intraoperative picture showing the lipoma. This patient is having a target sign. The clue is on the right lumbar region. This patient is a known malignancy. Now presenting with a small
Polyp.
This patient is a known RCC, now presenting with the target sign in the small bowel.
Submucosal metastasis.
Exactly. It's a metastasis now. The first case, the lead point is lipoma. The second case, the lead point is metastasis, which is obstructing the large bowel here.
Some irregular mass-like lesion.
The most common malignancy of the large bowel is
adenocarcinoma.
This is a case of adenocarcinoma. Okay. The most common CP angle lesion which obstructs the ventricular system is
Schwannoma.
Very good. Here also there is a ventricular system obstruction. Now the obstruction is at the level of foramen of Monro. Okay. The clue is in the CTs.
Subependymal.
Yeah. Full diagnosis, please.
Subependymal giant cell astrocytoma.
Yeah. Why? What's the clue in the CT?
Calcification is
where?
In subependymal region there
are calcifications. So this is a case of tuberous sclerosis with subependymal calcification and SIGA in the foramen of Monro obstructing the ventricular system. Which central tumor commonly obstructs the bronchi in the young female? Carcinoid. Very good. Which tumor obstructs the urinary system very commonly?
TCC.
TCC. Very good. Biliary system?
Calculi periampullary carcinoma.
Very good. Okay. So that's all for you. Okay. 4. That's it. Number 4 is you guys. Okay. Screen the whole body. See, in daily practice, sometimes we may be the first person to see the patient as a whole. The patient comes for imaging of one part, you decide to screen, and you pick up the answer. The patient comes for the question, you pick up the answer. Chest pain. Patient is having chest pain. One clue is there in the images, the ribs.
Metastasis is there.
Oh no. I'll explain to you.
Fat embolism can be fat embolism.
I'll explain to you. Bilateral, symmetrical, you can see the fractures in the posterior end of ribs. Any idea now? Okay, we'll screen the body. This file is screen the whole body, okay? We'll go to the scapula. I am seeing bilateral symmetrical fractures in the axillary end of scapula. I am seeing the bilateral symmetrical fractures in the medial end of femurs. Now any idea?
Pseudofractures. That's pseudofractures. Pseudofractures.
Yeah, exactly. So what do we want to screen? By saying pseudofractures, we are going in the line of hyperparathyroidism. So what do you want to do next?
Ultrasound
Okay. What do you expect in the skull vault?
brown tumors can be there.
Yeah, exactly. No, there is no ultrasound. I give you the CT.
Parathyroid.
You can see the parathyroid adenoma in the near the right lobe of thyroid gland. So here first we picked up all the pseudofractures. The patient came with chest pain. You picked up the pseudofractures. Then you decided, okay, we'll screen the patient's entire body. And later you picked up the parathyroid adenoma and gave the patient the answer. If you suspect crooked bugs, what do you do next?
Stomach, will screen stomach
Okay.
for the carcinoma.
Not always. Where is the primary this time?
Hilar cholangiocarcinoma.
It's from the gallbladder.
Okay.
It's a spot.
ECD.
Bilateral, extensive periosteal reactions along the femurs, tibia. The diagnosis?
HPOA. No, HPOA.
Yeah, exactly. Yeah, louder please.
Hypertrophic osteoarthropathy.
Okay, you want to screen anything?
As a lung
Yeah.
mass can be there.
Okay, we picked up the lung malignancy. Okay, fine. This patient had a little altered consciousness and weakness. The smart radiology resident picks up the edema in the cervical spinal cord. Okay, the resident decided to screen. Next, what's the next step? I want to screen the entire spinal cord.
Yes, sir.
Okay, that's going to be the step. Yeah, I have given you a T2 and a contrast enhanced MRI.
An enhancing lesion is there in the spinal cord.
Okay, now you give me two differentials.
Can be Hemangioblastoma is one thing, and
Okay.
ependymoma.
Yeah, both are very common. The most rare diagnosis metastasis.
Yes.
Okay, okay. If you suspect metastasis, the resident again ask the patient whether the patient is having any other abnormalities and landed up in
Breast mass.
Yeah. So you summarize all the findings. There's a patient case CA breast with a cord metastasis and single metastasis, which presented as MRI for MRI brain. So that's how the screening whole body is very important. This is very most common in our settings. A child with swelling, scalp swellings, proptosis.
Neuroblastoma.
You screen the abdomen and you pick up the neuroblastoma. Very good. Okay, that's it. So the patient comes for imaging of one part. The radiologist decides to go further. So that's the point. This is the video dedicated to the organizing team, Dr. Rajesh. Volume.
மாமா
என்ன மாமா வந்துட்டானா?
இல்லப்பா ஒரு கார் மட்டும் வருது, அதுல 5 பேர் இருக்காங்க.
அதுல கனி இருக்கானா?
அதுல கனி இல்லப்பா. ஏப்பா ரெண்டாவது கார் வருது, அதுல 5 பேர் இருக்கா, அதுல கனி இருக்கா.
வந்துட்டானா?
பதட்டப்படாதீங்க மாமா.
மாப்ள தலை துண்டா?
ஆமா, தலை துண்டா, கழுத்து துண்டா, குடலு துண்டா, ஈரல் துண்டா, சும்மா தனித்தனியா பிரிச்சு வச்சிடுறேன்.
அவ்வளவு வெறி மாப்பிளைக்கு?
எல்லாம் உங்களுக்காக மாமா. கூட எத்தனை பேர் வராங்கன்னு கேளுங்க.
சாமி கூட எத்தனை பேர் வரானுங்க?
ஆக மொத்தம் 10 பேர் வர்றாங்கப்பா.
2 வண்டியில 10 பேர் வராங்களா மாப்ள?
அவங்களுக்கு அதேதான் சொல்லுங்க.
அவனுங்களுக்கு அதேதான் சாமியார்.
ஐயோ பின்னாடி டிராக்டர்ல 50 பேர் வர்றாங்கப்பா.
என்னது 50 பேர் டிராக்டர் வரானுங்களா? மாப்ள அவனுக்கு சைடு 50 பேர், நம்ம சைடு 50 பேர், சரியா இருக்குமா?
கவலைப்படாதீங்க மாமா. உங்க மாப்பிள்ள வேட்டி இறக்கி விட்டாண்ட சாதாரண மனுஷன், அதே வேட்டியை தூக்கி மடிச்சு காட்டினாண்டா மதம் கொண்ட யானை.
மதம் கொண்ட யானை இருக்குடா.
ஐயோ லாரியில 100 பேர் வர்றாங்களையா, 100 பேர் வர்றாங்களா?
எக்ஸ்ட்ரா ஒரு லாரி, அதுல 100 பேரா?
படையே வந்தாலும் தடையே இல்லாம நான் முடிச்சு கொடுக்குறேன் மாமா.
எப்படி மாப்ள?
தண்ணியை கொஞ்சம் சேர்த்து ஊத்துனா சரியா வருது
அப்படின்ற
சமாளிப்போம் மாமா. ஊத்துவான்.
யோ என்னையா லாரி, ஊரே வந்தாலும் நான் சமாளிப்பையா.
ஊரே வருது.
ஊரே வருதா மாப்ள?
அட வரட்டும் மாமா, நீங்க வர தலைக்கு 2 துண்டை போட்டு விருந்த முடிச்சு வீட்டுக்கு அனுப்புறத விட்டுட்டு என்ன தகச்சு போய் நிக்கிறீங்க.
So we don't know what the scorer Dr. Rajesh has done in the menu. I don't know actually. Okay, number 5. Okay, when the tumors undergo, many tumors they undergo torsion, and the first presentation is torsion. So this what's the sign in the second image? It's a whirlpool sign. Okay, there's a large cystic mass lesion encircling all the bowel loops. That's the reason for the whirlpool. Just give me a guess. Okay, it's a mesenteric cystic lymphangioma encircling the bowel loops, causing the whirlpool sign. Okay, we pick up whirlpool sign. Not only we stop with that, we search for any underlying tumors. So that's the point. Okay, in this patient you picked up the whirlpool tumor, you able to make out the whirlpool sign, but there is a reason for the whirlpool. You see there are multiple fat dense lesions in the submucosal location of the jejunum, in all the jejunal bowel loops. You see this jejunal bowel loop 1, 2, 3. Okay, everything is studded with the multiple jejunal lipomas. That is the reason for jejunal valvulus due to that lipomatosis. Okay, that's the reason for the whirlpool sign. What is the diagnosis? Simple diagnosis. Left ovarian, your mic is not on actually. Left ovarian torsion. Okay, this is a right ovarian torsion, but not only the simple right ovary is some abnormality is there in the right ovary.
Necrosis.
No, there is an underlying T2, heavily T2 hypoindense tumor.
Fibroma.
Exactly, this is a fibroma which has gone for a torsion. This patient is having a mass, unexplained mass in the retroperitoneum. The clue is in the left spermatic cord level.
Undescended testis with the testicular malignancy.
Very good. It's a seminoma in an undescended testis. Another patient, this time the patient is having right side undescended testis, and the seminoma is formed in the right iliac fossa. Now the patient presents with acute abdominal pain. What is the explanation? Torsion, exactly. You compare the imaging appearances with the intra picture, how the you see the whirlpool sign, how the vascular pedicle got twisted, everything. Okay, so the first case is mesenteric lymphangioma. Then I showed you jejunal lipomatosis, ovarian fibroma, seminoma in the undescended testis. All they presented with the torsion as the first problem. Okay, that's the important point. 6. Who is having 6? Okay. Ready? Okay. So imaging of the treatment, so the oncotherapy, surgery, radiation, chemo, all cause lots of changes in the body. I will give you some very simple examples. CA cervix.
Radiation induced.
Radiation induced fatty marrow changes. Patient on methotrexate. Sudden altered GCS.
Methotrexate induced leukoencephalopathy.
That is one possibility. Acute. You just carefully see the CT, how the hypodensities involve the
White matter.
Yeah, it involves the basically the parieto-occipital lobes. Can a methotrexate induced press? Is it a possibility?
Yes.
This is a patient on bleomycin.
Pulmonary fibrosis.
Yeah, exactly. Not very early changes like NSAP pattern. You see some ground glass central lobular nodules also. It's not yet, the fibrosis has not yet developed, but this is bleomycin induced lung damage. The patient has had a radiation for thymoma. The patient is having pneumonia changes, 3/4 involving the right lung and 1/4 involving the left lung. This characteristically occurs in only one condition. The patient had a radiation exactly to the mediastinum. It's a radiation-induced lung changes. This is how it occurs. 3/4 on the right side, 1/4 on the left side. Because if a clear demarcation, it confines to the radiation port, then the pneumonia develops like this only. The patient had periampullary CA. Now the patient had a radiation to the para-aortic region. The patient is having vomiting, excessive vomiting.
Stricture.
Exactly. This is a radiation-induced gastric stricture. A case of craniopharyngioma post-radiation. Everything is spotous.
Basal ganglia cancer.
What is that called as?
FARS.
It's a mineralizing microangiopathy, complication of cranial radiotherapy and chemotherapy. That's it. Team 7. Sorry, case file 7 for team you guys. Okay. For when the tumors rupture, sometimes the tumors, the first presentation is itself rupture. Yes, I have given the SWA image to slightly for misguide you. Sudden altered sensorium. What are the things blooms in SWA?
Bleed, calcifications.
Calcification blooms, blood blooms. Whether fat blooms, yes or no? Yes, I'll give you the T1. Ruptured derma. Now the answer is very easy when I give you the T1. But when I give you the SWA, you are little complicated. Okay. So another example of companion case with dermoid with rupture. Okay. This is the most common tumor, liver tumor which ruptures. HCC. Very good. There's the pneumoperitoneum. Which malignancy rupture will give you pneumoperitoneum? Circumferential wall thickening seen involving the sigmoid colon with the perisigmoid fluid collection. Adenocarcinoma. Very good. The diagnosis? Fine, low density lesions, scalloping, finely scalloping the liver and splenic surfaces.
Mucinous carcinoma.
Pseudomyxoma peritoneum. What do you do next? Which ruptures?
Appendix.
What's the diagnosis?
Appendix
Mucocele of the appendix. Okay. Okay, this is a very interesting case. This is not a tumor rupture. This is something, an iatrogenic rupture for when evaluating the tumor. This patient is a known case of OG junction malignancy. Endoscopy was done. Immediately, the patient slightly deteriorated. The scanogram. Which is obvious, striking. Pneumomediastinum. The striking is pneumomediastinum. They done endoscopy, the patient is developing pneumomediastinum. What does it mean?
Esophageal rupture.
Yeah, what does it mean?
Esophageal rupture.
Esophageal rupture, okay. So I have given some 50 ml of oral contrast and try to opacify the lumen of esophagus. How many lumens are there for the esophagus? 1, there is a flap. 2. What does it mean? Dissection. So normally the dissection happens in aorta. But how dissection happens in the esophagus? So where this the contrast in the left side is leaking? Between which layers? Because esophagus is having only 3 layers. Okay, the contrast is going between the mucosa submucosal layer separate and muscularis layer separate. So you see the flap and you see the contrast on the left side is dense and the contrast in the false lumen is little lesser dense. Okay. So this is a coronal reconstruction, shows the lumen and the true lumen and the false lumen. The contrast in the true lumen flows freely into the stomach. So this is a case of esophageal dissection. Okay, last file. Rajesh, you are ready? You are ready with the marks? The number 1, number 2, number 3 team is ready? Okay, last case file. Yeah. Can you give the path diagnosis? See, we radiologists don't need to give the pathological diagnosis every time. Okay? So, sometimes the things are antimony. Bilateral fat dense lesions with some areas of soft tissue attenuation encircling the kidneys and deforming the kidneys smoothly. I'll give you 3 differentials. That's a classical example of perirenal, extraadrenal myelolipomas. See, myelolipomas are common in adrenal gland. They come extraadrenal, they come in the perirenal locations. We found a cavitary lesion in the left lower lobe. Okay, the patient had cyclical hemoptysis. The history itself gives the diagnosis.
Endometriosis.
Yeah, exactly. So we have done a biopsy of the lesion, it turned out to be endometriosis. Suppose if the patient is having cyclical hematuria with this bladder lesion, again endometriosis. So we are giving the pathological diagnosis very confidently. An elderly guy, when you see a soft tissue tumor with a bunch of specks of calcification along the line of urachus, can you give the different diagnosis? Because only 1 malignancy comes in the urachal remnant.
Adenocarcinoma.
Exactly, this is urachal adenocarcinoma. So these are some examples where we can give the pathological diagnosis very confidently. This patient, 43 years female, lower abdominal pain and hypertension on amlodipine for 2 years. The patient showed a well-defined, finely enhancing mass lesion with some internal low densities. My first question is it benign or malignant? I have given you a TCC also for your comparison. Well-defined, smooth-walled, benign or malignant first?
Benign.
Benign, okay. So give me some 2 or 3 examples of benign bladder tumors. Any 2 examples? Lipoma, neurofibroma, okay, fine. We have also given 2 or 3 differential diagnoses for benign. but we have never given that particular pathological diagnosis. So in the dissection, the BP shoots up to 260. The patient had a hypertensive crisis. Now, what is the diagnosis?
Pheochromocytoma.
Exactly. So that's the diagnosis. So one diagnosis, all other antimony, even though if you don't give diagnosis, path diagnosis, there's nothing happens. But one diagnosis we can suggest is paraganglioma, because to avoid hypertensive crisis. I have given 3 examples. All the tumors are in the periduodenal location, but they are looking very similar. One is GIST, 2 is paraganglioma, 3 is malignant nerve sheath tumor. Remember, again, this is the take-home point from this session. The one path diagnosis we can suggest is paraganglioma. I think there will not be any tie. Rajesh, am I correct? Now you can please announce the. Just give. Yeah. Yes, sir. Yes,
Ganesh,
sir.
1 second. I think we should first congratulate our quiz masters, Dr. Ganesh and Dr. Arun Ramaraj. Give them a big hand. I think we learned a lot by these cases many of the time, rather than sometimes listening to big lectures. And that's the way, like, they have shown some fantastic. Thank you, Arun. Thank you, Ganesh. I think you both have done a lot of dual shows at all India level as well for our national quiz, and it has been a phenomenally appreciated thing. And we are hoping just that we might see you in Vellore as well this year end. All right. Thank you, Rajesh. You are a good scorer.
Thank you, sir.
So, Rajesh, I need number 3 first. Number 3. I congratulate all the 8 teams, because I heard the story that you have been selected from 45 teams. The 50 teams, they have competed. The final 8 teams are there. Now there are the first 3 teams. Number 3 first. You can announce, please. Which college?
Yeah. Team 8. Which college?
Which college?
Stanley.
So
yeah,
Stanley Medical College comes 3rd.
And they scored 230 marks.
Very good. Team 2.
It is team 4.
Okay, please. You are from? Okay. Vadabalani Hospitals, Madurai. They come team 2. Second.
So they scored
very good.
240 marks.
Very good, very good.
And
so the winner is?
Any guesses?
Any guesses? Somebody is saying team 3. Okay, we'll see. Team 3? Yeah, you guys. So you are from?
Ramakrishna.
So Sri Ramakrishna Hospitals, Coimbatore. So the quiz masters students. Am I correct? The quiz masters students. Very good. Okay. So when we are going to give the prizes? Tomorrow you please come and collect your prizes. All the best. Thank you.
So I congratulate all the teams, and I thank you for Ganesh sir and Arun sir for their excellent cases, and thank you very much sir for your funny video. It gave a lot of relaxation in the stressed mood.
Yeah. Please enjoy the night dinner also.
Thank you, sir.
Thank you so much.